Starting off today, we have Professor Ben White from the Australian Centre for Health Law Research, Queensland University of Technology. His topic is voluntary assisted dying. Professor White.
Thanks. Thank you, Hudson. And I'll just attempt to share my screen. Hang on. I'm afraid I'm just getting a message saying that screen sharing disabled for me, unfortunately.
Just one moment.
We'll fix that.
No worries. Thank you. And look, while that's happening, I'll too acknowledge the traditional owners, the land on which we're gathered. And say thanks to Fiona McDonald from the QT HREC, who extended the kind invitation to talk about voluntary assisted dying and some of the research ethics implications there. I'll acknowledge to my colleague Lindy Wilmot. The work that I do here is all with her, so a lot of the stuff I'll be talking about today, and also Eliana Close, a bunch of this works with her, and she helped me with some of the PowerPoints too. I guess perhaps before getting the slides up, it's easy to give a disclaimer. Lawyers are good at disclaimers, so I should probably give one here. And that's that it was a bit daunting to be asked to talk about research ethics. So obviously I'm a researcher working in voluntary assisted dying, but I'm not living and breathing research ethics like the folks who are tuning into this conference. So while I enjoyed a period on the QT HREC, I won't pretend to have any particular expertise other than a researcher who's thinking about it. And I guess grateful for the colleagues who've helped me think some more deeply about these research ethics implications. So shall I have a go at sharing screen again?
Yes, have a go.
Okay. No, I think I'm still disabled, unfortunately.
I'm sorry, I'll try and sort it for you.
No worries, that's all right. Would it help if I emailed the PowerPoints to you? Is there another way?
Yep, you can do that as well. Yeah.
All right, no worries. I'll do that quickly, and then I might just dive in if that's all right.
Yeah, and I'll see if I can fix it as well.
Thank you so much. All right, just email them through it. And Sarah, shall I just keep going? Does that sound okay?
Sorry, Ben.
Shall I just keep going?
Yes, if you're happy to.
Yes. All right, brilliant. I'll do that. This work that I'm doing is done with a bunch of colleagues. There's a slide which acknowledges them all. I won't read them out, but just to thank the teams that I have a chance to work with on this voluntary assisted dying work. So in terms of what I'll talk about today, I will give a little bit of background and context to voluntary assisted dying. I'm conscious that while this is something that's in media and public debates, different people have different views on this. And we've all been to the barbecue where people are talking about the same topic, but actually have very different understandings. So I might just give a bit of a snapshot about voluntary assisted dying. I'll talk briefly about a couple of projects where we have applied for research ethics. So that will give a little flavour of I guess some of the sorts of methods and participants to shape that discussion. And then I'll conclude with some research ethics reflections, things that we've been thinking about in the course of this work. So thinking first about voluntary assisted dying, in terms of the concept, it really is about the taking of active steps that enables a person to die. There's different terminology, and you would have heard these in debates as well. Things like medical assistance in dying, physician-assisted suicide, euthanasia, all those sorts of terminology have been in sort of current debates. Voluntary assisted dying is the terminology that I'll be using. This is the language that's now used in Australia, for example, in the legislation in Victoria. There's two types of voluntary assisted dying. So one is...
Ben, can I just say, you should be able to share your slides now, sorry.
Fantastic. No, that's great.
It's not come through to myself yet. Yeah, there you go, thank you.
Slides up, fantastic, thank you. Thanks all. So there we go. There's the colleagues I mentioned before. And in terms of thinking about voluntary assisted dying, spoken about the different types of terminology. There's two types. One's called self-administration. That's where a patient is provided with a prescription or medication and they take the voluntary assisted dying substance themselves. Or there's what's called practitioner administration, where a doctor or a nurse practitioner, for example, in Western Australia in their forthcoming law, is able to provide the bad substance via injection or via IV or whatever it might be. So important also to think about, while we're talking about voluntary assisted dying, this is just one type of end-of-life decision that occurs in medicine. And in a country like Australia, which is highly medicalised and a very advanced health system, about 65% of all Australian deaths have some kind of medical decision that precedes death. So the last one on the last of the three types you can see, euthanasia, physician-assisted suicide, now called VAD, that's the abbreviation that I'll use. But worth mentioning the other two that you can see on the slide. So whereas voluntary assisted dying, for example, might be administering medication with the intention of someone dying, the first one on the slide, there's no intention for death to occur. This is palliative medication where someone has pain or symptoms and they may need medication to deal with that. It may be foreshadowed, maybe foreseen that it might have life-shortening effects. The person's life may be ended more quickly than otherwise would be the case. The intention isn't to do that. An intention instead is to relieve pain and suffering. That is lawful and has always been lawful in Australia. So that's another type of decision at the end of life. And the other one to distinguish from voluntary assisted dying is where treatment is withheld or withdrawn. So whereas voluntary assisted dying might involve administering medication, this is about not providing treatment. So for example, withholding a ventilator or withdrawing a ventilator, knowing that someone's going to die, again, has a long history of being lawful in Australia. That context is important because obviously both of those two other types of medical end-of-life decisions are lawful in Australia. And with voluntary assisted dying now also being lawful in some jurisdictions, it's possible that ethics committees may be considered to distinguish between these three types of decisions. So we are seeing increasingly voluntary assisted dying becoming lawful internationally. There's a slow but steady trend that we see internationally and also happening in Australia. This is a function of the high degree of public support. I think it's 75–80%, depending on how surveys are framed, support this. Integral to law reform has been the growing body of social science evidence that shows how these systems work in other countries, and political and social changes, baby boomers coming through saying they want control. So what we're seeing, and I think we're likely to see in Australia, is that increasingly states around Australia will change their laws to permit this. The point I guess I wanted to make here is this remains strongly vexed, very, very controversial. This has obviously got implications for law reform and how things are implemented in terms of system design, but it also has significant implications for research ethics. If voluntary assisted dying is lawful, but highly controversial and very contested within different settings, that has implications for research ethics, some of which I'll talk about shortly. I won't give you the world tour, but you can see very quickly that in both North America and Europe, there are a number of jurisdictions where this has been lawful. And if you look at some of those dates, you can see things, particularly in the US, that things are increasingly happening quite quickly with a number of jurisdictions changing their laws. In terms of, I guess, the miscellaneous other category, we have Colombia and now New Zealand. So New Zealand law passed its parliament, and most recently the election, the referendum there endorsed that law to come into force in 12 months. So there is, as I mentioned, this slow but steady shift internationally in allowing voluntary assisted dying. And we will see that in Australia too. There's discussions about this being a train that's left the station and will slowly roll out across the country. In Victoria, the law was passed in 2017, so almost 3 years ago, but there was an 18-month period of implementation before that law came into force, and we were approaching 18 months of that law being in operation. Western Australia also has a law passed, and in approximately 6 to 8 months, they anticipate the law will start there. And the other 3 states that are actively considering reform are Queensland, South Australia, and Tasmania. So in Queensland, you can see if you were based in Queensland, you would have seen lots of discussion about this topic during the election with the Labor Party, if re-elected as it was, undertaking to introduce legislation in February. So there was a parliamentary committee that considered this, which said there should be law. It's with the Law Reform Commission to draft a bill, and there will be a bill according to the Labor Party's promise in February. Tasmania is actively considering a bill. Its 2 houses of parliament passed the upper house, and remarkably, 15-0. So while these are very contested issues, often you see in parliament margins that reflect that divergence in view. All 15 MPs in the upper house in Tasmania voted to pass the bill there. So currently with the lower house for consideration, South Australia will introduce a bill as well. So while there is only Victoria at the moment, and correspondingly very limited pockets of research, research ethics committees, as this law changes, I anticipate will see increasing applications as people want to study this new and controversial and challenging area of law and medical practice. So just to give a very quick snapshot about what the Victorian law looks like, and this is the final slide in terms of that context. And I think this is useful because it's, again, coming back to that earlier point, we've all had conversations at barbecues, everyone's, thinks they're talking about the same thing, but sometimes actually that the nature of the law is quite important to frame what sort of discussion we're having. I'll mention the Victorian law, but this kind of model appears to be what Australian states are adopting. So there is this model which seems to be rolling out across the country in broadly these terms. And it's probably safe to say it is the most conservative and narrowest model internationally. So there's debates about is this tighter or narrower or more conservative than this model. But the Victorian model, I think, is largely recognised as a very narrow, a very safe, a very highly regulated approach. So adults over the age of 18 who are Australian citizens or permanent residents and must be residents of Victoria are able to access voluntary assisted dying if they have a condition that will cause their death, and that death is expected within 6 months or 12 months if the condition they have is neurodegenerative, and they also have to be experiencing suffering. The decision has to be made by the person in a voluntary way. There has to be their own decision that has to be tested and has to be enduring over time, and importantly, they also have to have decision-making capacity. And if all those criteria are met, I mentioned before the idea of self-administration, where someone takes the medication themselves, or practitioner administration. The Victorian Act has as its default self-administration. Someone can be prescribed medication which they can take, only if that's not physically possible. If they can't digest or swallow, is practitioner administration permitted. So I guess a snapshot of just a few projects. Again, I won't spend too much time here, but I thought it might be useful just to get a little bit of meat on the bones in terms of, so having given a bit of context about what voluntary assisted dying is and looks like and what's likely to happen, I think, in Australia. In terms of some of the research projects, to look at it, to think about the research ethics considerations that arise, perhaps useful to see some of the methods and some of the research questions that are there, but this will be brief. The first is an ARC Future Fellowship, aiming to look at optimal regulation of voluntary assisted dying in Australia. It also has a Canadian and Belgian component as well. I won't say too much more about that. In short, it aims to understand not just how law works, not just how policy works, or not just how one sort of part of the picture works, but actually understand the global regulatory forces in play. So that's the theoretical underpinning of this project, but perhaps in a more concrete way. Instead of, as I said, there's a lot of research looking at just what the law says, or lots of research looking at what policies say. We're aiming to understand how voluntary assisted dying is regulated in Australia and how it affects doctors, health professionals, patients, families, and indeed the regulators themselves. So in terms of some of the research methods, semi-structured interviews, there's obviously, you would have seen from the slide, a bunch of looking at laws and policies and those sorts of things, but of particular interest for today's discussion is semi-structured qualitative interviews with the folks who you can see on the slide there, doctors and health professionals who are involved in voluntary assisted dying, significantly terminally ill patients and their families. So that would include those who are seeking to have access to voluntary assisted dying and may not succeed, and those who have been successful in navigating the process and are eligible, and of course their families as well, to report on some of those perspectives. We also want to understand regulators' perspectives on how this regulation is working. So there's an oversight body called the Voluntary Assisted Dying Review Board in Victoria, and most of the models internationally have that. The Department of Health and indeed others. We'll also have some expert roundtables of experts in the field to try and develop some of those regulatory models. A second project aims to look at the first year of the Victorian voluntary assisted dying system. So as I mentioned before, that's been in force now for 18 months, and we're interested to learn how it was going in its first year. This is the first time since in the mid-1990s, when the Northern Territory had a very brief window of a voluntary assisted dying system. First time in 20 years this has happened in Australia. So to understand how the system is working. It's a relatively modest project, so we're only able to look at some aspects of it, but research methods here include interviews with doctors who have been involved in providing voluntary assisted dying and their reflections and observations on how that regulatory system is working. The third and final project I'll mention is looking at the voluntary assisted dying training program. So one of the safeguards I mentioned before, that Victoria has a very prescriptive, a very focused system of regulation for voluntary assisted dying. And as part of that, every doctor who has to assess or who wishes to assess eligibility has to undertake mandatory training. So the theory was to make sure that everyone who's involved has a baseline level of knowledge. That training was provided by the team you can see there on the slide. And the research methods that we're using to evaluate the training and thinking about how it could be improved or how it worked was sort of some focus group training, focus group testing rather, the train at the beginning. And there's also a survey of user experience. So that's, I guess, having given a bit of a snapshot about what voluntary assisted dying is and some of the projects and methods that our research team is using to look at this. We wanted to turn now to think about some of the research ethics issues or questions, and I've deliberately framed this in an open way. This is where I shift from feeling like I know a little bit about something to being a student again. So I should acknowledge I'm very grateful for the support and I guess advice from the QUT HREC as we were putting these project and other projects for consideration. lots and lots of feedback, lots of engagement and discussion to help me and the wider team reflect on the research ethics issues here, particularly from Fiona McDonald, who's the Deputy Chair. Lots and lots of discussions and advice, which was very helpful. And also Connor Brophy, the Chair of the QT HREC as well, has also been very supportive of helping us think through these issues too. And it would be remiss of me if I didn't mention my colleague, Dr. Rachel Feeney, who's an integral part of our research team, has done a lot of work on the research ethics applications within the team, and a great colleague to debate and discuss research ethics about as well. So with some trepidation, I will share my 2 cents worth on some of the conversations and discussions we've had about research ethics issues for voluntary assisted dying. My starting point would be the national statement. I recognise there are some consultations on changes, including about things like vulnerability, which will undoubtedly, depending on where that lands, have impact on this sort of research and the participants involved. But I might just, I guess, approach it like I would a research ethics application and sort of work through the national statement and pick up some of the issues that I think might be worth considering. This isn't comprehensive, so there's probably other issues which I won't have time or won't touch on, but hopefully of some use. So when thinking about potential harms and how they might be managed and engaged, I think one of the things to note right at the outset is the diverse participant groups. So obviously I spoke about patients who may be seeking voluntary assisted dying or may be approved as eligible for voluntary assisted dying, their families, doctors who may be assessing patients or indeed actually providing voluntary assisted dying if it's practitioner administration, other health professionals nurses, allied health, who may not actively be involved in the provision of it, but of course are present and part of those discussions as well. And of course, regulators too. And when thinking about this diversity of participant groups, and especially thinking about harms, one of the things that we had at the forefront of our mind was the continuing controversy that exists around voluntary assisted dying. Yes, it's legal, but it is a very vexed issue. And one of the challenges, I think, for sort of thinking about how participants may experience research and some of the possible harms is to note that controversy. So to give an example, and this is an example I might come back to, it may be a little cliche, but it is very significant and front of mind. Historically, the palliative care specialty has opposed voluntary assisted dying. That's not the case for all palliative care organisations, nor the case for all palliative care specialists or nurses or others in the palliative care field. Indeed, there's a number of palliative care physicians who have been at the forefront of providing VAD, which they see as actually part of caring for their patients. But there is different views in there. So, I guess thinking, just jumping to the social aspect of it, participating in research about voluntary assisted dying because they've provided it, that may be significant risk of stigma or other issues in the workplaces. For example, in a palliative care unit where there's 3 doctors who are vehemently opposed and 3 doctors who may be supportive or prepared to provide it. There's obviously the stress aspects. That's particularly significant when talking about patients and families, of course. But also the case for clinicians as well. Even very experienced people who have had many, many years of experience in providing end-of-life care. Voluntary assisted dying is new, and it does involve a different type of care at the end of life. And so someone who may feel very comfortable with providing palliative care or nursing or nursing a patient to the end of life may feel quite differently about voluntary assisted dying. So we were cognizant of those different types of aspects. I will mention the legal aspects and possible legal harms. And I guess this arises where there's potentially questions about boundaries of lawfulness. But one point I did want to make is that there is an important conceptual shift I think is significant when thinking about these issues, and that is this is now a lawful health service. So in Victoria, this is explicitly framed as a health service and a lawful one. So questions when thinking about potential legal risk, I think are different now when researching about voluntary assisted dying that's occurring within the BAD regime. Now, I'll talk a little bit more about that later on. That's not to say that legal issues or legal risks aren't relevant, but I think it's quite different now when researching into VAD from before, because before, by definition, you were researching an unlawful practice. And so there's a different type of legal harm that might arise here. I guess when thinking about the harms that were there, we were balancing when thinking about the research, the possible benefits as well. Folks would be familiar with the wide literature in a range of different settings about the benefits that participants often report by talking about whatever the research might be about. Here it's voluntary assisted dying. There is a body of literature which talks about the benefits that some patients, for example, and families talk about when in end-of-life care generally. And I just thought I might take the chance to note that one of those studies I mentioned before, interviewing a range of doctors, about 30 doctors, about their involvement in voluntary assisted dying. One of the things that came through very clearly was actually the benefits that the doctors, they really enjoyed talking about it and found it quite therapeutic and beneficial. We don't want to get carried away with that or take that too far, but we just noted that was very significant, and that's, I guess, partly a function of voluntary assisted dying, some of those stigma issues. Some colleagues felt, actually, I don't really have too many people to talk about this, or this is the first chance I've really had a good chance to debrief about this. So that was one of the things that we've noted in that and consider and will consider in future research ethics applications. In terms of things like use of data and recruitment. So when thinking, for example, about doctors, when trying to find folks who are involved in voluntary assisted dying, there is no official list of voluntary assisted dying doctors. If, for example, you wanted to do some research on ICU doctors, it's possible to obtain lists or recruit through different ways, but more challenging with voluntary assisted dying. Likewise, challenges for snowballing. So if you wanted to try and reach other doctors, in part because of some of these stigma issues, being able to say, hey, look, thank you for your time today. Is there anyone else who's involved in voluntary assisted dying who you think we might be able to talk to? Some of the responses were, look, I don't know. People aren't really talking about it. It's very new. There's a lot of anxiety about it. So there's some issues that go with that. Likewise for identification as well, in the way in which data is reported. I mentioned before some issues in palliative care setting. Palliative care, for example, is a relatively small field compared to other specialties. So talking about a palliative care specialist outside a metropolitan area of a particular gender and of a particular age, while that might be okay in emergency medicine, because that wouldn't identify the size of the emergency cohort, may be an issue. So something that we've been thinking carefully about. There's long-standing challenges of recruiting patients and families and doing so in a sensitive way in end-of-life care generally. And we've also seen that as well for VAD. I guess to conclude, to think the last few slides, just think about those specific situations or participant categories in the national statement. I'm thinking here about people highly dependent on medical care. This is obviously research. The work that we do isn't physically invasive, but there is, of course, a risk of distress to be particularly aware of. That chapter of the national statement cautions particular attention to be paid to capacity issues. This is an interesting one for voluntary assisted dying because whereas a lot of features of voluntary assisted dying make research ethics more complex and more challenging, one of the things you would have seen from the legal regime of voluntary assisted dying is that there's a requirement to be assessed as having capacity. And 2 doctors have to do that. So you have a capacity assessment undertaken by 2 doctors. Very often, if you're talking to end-of-life patients in another setting, there won't be that sort of confidence that this patient's been assessed for capacity. So interestingly, that is one area where if you're talking to a patient who has recently been assessed as having capacity as part of that voluntary assisted dying process, that actually may be a benefit of this sort of cohort. Of course, patients can lose capacity, and we also want to speak to people prior or as they're going through the voluntary assisted dying process. So that remains important. The outcomes of the sort of research that we aim to do is about improving systems, better, more efficient systems for patients, better safeguards, all those sorts of things. Again, thinking about the desire to participate in research, we have to be very clear about the vagaries of those outcomes and timing. A lot of patients, as folks would know, are interested in participating for that legacy reason. So I guess one of the things we're conscious of when working with patient participants in this setting is being really clear about, although this research aims to improve practice and aims to improve law, but there are so many variables about whether that changes and so on. People who may be involved in illegal activities, another chapter in the national statement. And I mentioned before, our research here is really focusing on where voluntary assisted dying is legal. And this is quite different from the previous sorts of studies where voluntary assisted dying wasn't lawful. So by definition, it was examining illegal activity. There are decisions about end-of-life care and end-of-life decision-making and where death can and indeed sometimes is intended to incur. So our view on this is that we're not intending to research intentionally illegal activities, but note that it's possible. So I've tried to deal with this issue in that way in the research ethics applications that have been put forward, and in particular dealing with warning and redirection strategies to avoid any possible issues as and when those arises. I guess thinking empirically, while it is possible for activities to occur outside the VAD system, which I guess would put it back to that sort of previous illegal body of work, thinking about the data that's there, the Voluntary Assisted Dying Review Board has published some studies, some data about the extent to which the compliance is occurring. And I think the compliance was listed at 99%. There was a small procedural matter that wasn't properly complied with. Otherwise, compliance was very, very high. So that's relevant, I think, to understanding this particular chapter. And I think that conceptual shift about this nature of research, I think important to, in a very clear way, take it out of the unlawful, illegal bucket and put it into the now lawful, but with issues possibly at the boundary. Look, just a final observation from a research ethics perspective is to think about the research team welfare. So some things, I guess, to note here that we've considered, not only in this research about voluntary assisted dying, but I guess other end-of-life research is thinking about the welfare of interviewers in particular. I mentioned before, we've done about 30 interviews with doctors, and having a protocol for welfare to make sure that whoever's doing the interview has enough time and space between interviews, regular check-ins with the person doing the interviews as a wider research team to see what issues arise. And that's where a lot of those discussions actually about doctors finding this quite therapeutic and valuable personally to talk about it. Other things we do is, I guess, have a welfare as a standing item at various meetings. So that way it doesn't sort of require someone to initiate and say, oh, look, I'm having trouble. It's something which is initiated as a matter of course. I think all of those are important, but actually I think some of the most important work occurs informally as well, and that sort of peer support from the wider research team. Something our research group is rain, hail or shine. Every Monday morning at 9:30, we go for coffee as a team. And lots of these things sort of come out during those steps and discussions and processes. A couple other notes, I guess, is providing breaks, particular projects or topics. So sometimes we have researchers who might say, hey, look, can I have a couple of weeks away from this work? And we've also made sure, thinking back to the research ethics applications themselves, this material can be sometimes confronting for transcribers. So including warnings and other sort of safeguards to make sure folks aren't taken by surprise. So that brings me to the end of this presentation. As I said, not an expert on research ethics, but I really enjoyed the opportunity to reflect some more about how that plays out in my field. So thank you.
Thank you, Professor White. We have a few questions from the audience. This is one you've alluded to, but what happens if a person makes the decision while they have capacity, but lose the capacity to consent before voluntary assisted dying is to be fulfilled?
Yeah, so under Australian law, they would not be eligible to receive voluntary assisted dying. So that the Victorian model, and this seems to be very clear in the models that are unfolding, that a person needs to have capacity to be able to access voluntary assisted dying. And if they lose that during the process or after that point, that's no longer available.
Do you know whether there's a professional body for doctors engaged in voluntary assisted dying?
I don't think there's a professional body as such. So, for example, like part of medicine has AMSPAM, the sort of a more formalised body. There is a community of practice which was set up by the Department of Health, I think initially, and then I think the doctors who were involved took some ownership of that. So I know that community of practice does have a supportive role for other doctors and debriefing role as well, but no professional sort of standalone body at this point.
Thank you. And Professor White, I draw your attention to a thriving side conversation that's been happening in the chat room regarding should the national statement consider death resulting from voluntary assisted dying as a harm or a benefit? That is, how should ethics committees view that? And the gist of the conversation was it's not a result of research intervention, so it's out of the scope of the national statement. And as there's tree work going on, as you can hear, I'm going to mute my mic as soon as I can. Thank you, Professor White.
Thank you.
Actually, Hudson, would you mind if I just ask Ben another question? Sorry, Ben.
Please do.
Just with respect to the doctors who make decisions, are they independent to yes. Do you have to have two independent arbiters to make a decision as to whether it's appropriate to go forward in addition to the actual doctor who might administer things?
Yes, so under the Victorian model, so there's subtle differences in WA, but I guess broadly the model always is that there are two doctors involved. There's what's called the coordinating doctor who has the carriage of the process. Often that's the person's treating doctor, but for example, if they've don't want to be involved, so that can sometimes be someone else, but there is a coordinating doctor who does all the assessments, manages the process, handles the paperwork. And then there's the consulting doctor, which I guess is like the second opinion. In some instances, so for example, if there's uncertainty about capacity or other things like that, there is specific scope to refer off to a third doctor to assess capacity. So there is scope to bring in others, but every person who has voluntary assisted dying will have a minimum of two doctors involved in those eligibility assessments.
Thank you, Ben. And just one final one, sorry, Hudson, because this was on the chat as well. Is there a list of doctors who are able to carry out this process? And if so, do they receive any education training on this important topic?
Very, very significant question in practice, because one of the challenges that people are reporting is not knowing who to approach if I'm interested in voluntary assisted dying, or not knowing who to refer to. In practice, this is managed by voluntary assisted dying care navigators. So there's, I think, 4 now in Victoria. These are state appointments, and doctors can volunteer to put their name on that list. So if someone's seeking voluntary assisted dying but can't find a doctor, they can contact one of the navigators who can put them in touch so that process or consideration can start.
Thank you, Ben. That concludes the questions from the chat room.
Thank you all.